To begin this lecture on musculoskeletal problems and the elderly, let's briefly overview joints in the human body. So there are 206 bones in the body, and joints are where there are two or more bones attached. Joints are classified by the degree of movement they permit. First, we have amphiarthrosis. These are slightly movable joints such as those between the vertebrae. Then we have diarthrosis, also known as synovial joints. They are more freely movable joints such as the knee or the hips. With these joints, we have different range of motion. For example, knees or elbows are like hinge joints. They can only flex or extend. Hips or shoulders have greater range of motion such as flexing, extending, abducting, adducting, or circumducting. We also have synarthrosis, which is an immovable joint such as the skull. We will overview more of our synovial joints because these joints are the ones with greatest degree of movement. The opposing surfaces are covered with a smooth layer of hyaline cartilage, a wide smooth surface that provides lubrication and allows the bones to move without actually sliding against each other. Depending on the type of arthritis, this hyaline cartilage can be depleted, which is then going to lead to the symptoms that patients may experience. What is synovium? This is the inner lining of the joint capsule, and this is going to produce synovial fluid. This fluid is like grease. It allows joints to move. Some types of arthritis will be affected by impairment of that synovial fluid, such as with rheumatoid arthritis. There are three different types of arthritis that we're going to go over. The first is inflammatory or autoimmune. Rheumatoid arthritis is the one that will affect adults and is chronic. There is also juvenile rheumatoid arthritis, but we will only cover adult rheumatoid arthritis. There is also degenerative arthritis, which includes osteoarthritis, another chronic disease. It is also known as DJD, or degenerative joint disease. Lastly, there is also inflammatory or metabolic arthritis. This is also known as gouty arthritis. Gouty arthritis is usually temporary and may have occasional flare-ups. Okay, so rheumatoid arthritis is a rapidly developing chronic autoimmune disorder. This is when the body attacks itself. Rheumatoid arthritis is found in joints. It typically affects individuals who are in their prime years of their lives. It could start as early as juvenile age, or it could be as early as maybe their 20s, 30s, or early 40s. It is not really well known what causes rheumatoid arthritis, but because it is an autoimmune disorder, there is great possibility that there is a strong genetic component to it. It is a well-known outcome of the disease that there is destruction, deformity, and disability. Sadly, once there is a joint damage, this will limit range of motion for these patients. Surgery may be needed to regain some mobility. For example, joint replacements are common surgical treatments for joint damage. Here we have listed the progression of rheumatoid arthritis. First, the synovium is going to thicken in the joint. This will then lead to the inflammation of that joint, making it feel hot or warm to touch and even swollen. Fluid continues to accumulate in the joint, making it more and more swollen, causing more discomfort and pain. Over time, pannus, an abnormal tissue or growth within the joint, begins to form. Soon, an erosion of the cartilage also occurs, and sometimes even erosion of the bones. As the disease progresses, there will be more fibrous adhesions and calcifications forming within the joint. Damage to the joint can lead to malalignment pain, and discomfort requiring surgery to relieve symptoms and improve mobility. Rheumatoid arthritis affects bilaterally, meaning if one hand starts to get affected, the other hand will become affected as well. Rheumatoid arthritis can affect hands, fingers, wrists, elbows, and as it progresses, it can affect other joints in the body as well. One key symptom of rheumatoid arthritis is morning stiffness. Patients will complain about morning stiffness that decreases as the day goes by. With rheumatoid arthritis, stiffness lasts for several hours, whereas with osteoarthritis, morning stiffness may last for an hour or less. With rheumatoid arthritis, it may affect almost every body system, and that's going to be mostly related to the fact that it's an autoimmune disorder. Remember that with autoimmune disorders, it affects other systems as well. A common complaint is fatigue or flu-like symptoms where the patients just don't feel well. They can have sporadic fevers that are typically low grade and general malaise or fatigue. They can also have weight loss, poor nutrition, or even lymph node enlargement due to the autoimmune disorder. Sjogren's syndrome is when they have dry glands. It affects the mouth, eyes, as well as the vaginal area. Rheumatoid nodules can also develop. They are small lumps of tissue that develop under the skin. They usually occur on the finger joints first. There's also swan-neck deformities that can occur in these patients. It affects the appearance of their fingers as seen here in these pictures. Diagnosis of rheumatoid arthritis is attained by looking at patient's history and physical. Does the patient have history of joint pain, joint swelling, or fatigue? For labs, a CBC can be done to see if a patient has anemia. There is also rheumatoid factor blood test, which helps us determine if the patient does have rheumatoid arthritis. An anti-nuclear antibody test will help to determine if they have an autoimmune disorder. If they do have a positive test, this helps to reinforce the diagnosis for rheumatoid arthritis. ESR can also be done, and if increased, it basically tells us that the patient has had chronic inflammation, such as with the autoimmune disorders like rheumatoid arthritis. Electrophoresis or immunoglobulins are also going to be elevated if they do have these tests. Radiology exams will include x-rays. These x-rays show us what the joint space is looking like and if they have deformities in these joints. CT or MRI can also be done to help look more closely at the soft tissues surrounding the joints. EMG or electromyography can also be done to measure muscle movement and muscle response times. Here we have the rheumatoid arthritis medication pyramid. First, we begin at the bottom with over-the-counter medications such as aspirin, which helps with inflammation. We next have NSAIDs, which help with inflammation but also help with discomfort and pain. We also have rheumatic agents and biological response modifiers. They are used for more aggressive forms of rheumatoid arthritis that basically has higher risk of deformities. Anti-inflammatory meds like aspirin and NSAIDs will be used first. Aspirin helps decrease inflammation, and NSAIDs help decrease inflammation but also decrease pain. We want to be careful when using these medications because they do increase the risk for GI bleeds. Steroid use is only going to be used for exacerbations of rheumatoid arthritis or if they need long-term remission. So if they tried other types of medications and they were not really effective or working, then they may need to start something like prednisone long-term. Prednisone is a steroid that can also lead to other complications later on These complications include increasing the risk for Cushing's syndrome, peptic ulcer disease, which also increases the risk for GI bleeding. These steroids can also lead to increased rates of osteoporosis. And when using these medications, make sure that patients are tapered down if needed. It's never recommended to abruptly stop prednisone use because it can lead to adrenal insufficiency. Remittive agents include DMARDs or BRMS. DMARDs are common ones used, such as methotrexate. This is a medication we worry about because it does cause some bone marrow suppression. This is a form of chemotherapy, and we worry about the same things that we do with our cancer patients. One of them being infections. So we have to monitor patients for signs and symptoms of infections. Biological response modifiers and tumor necrosis factor inhibitors can also be used to keep individuals in remission. Humira injections is an example of them. Usually patients are on a combination of these medications such as NSAIDs and a DMARD, or an NSAID and a BRM or TNF. The main goal for rheumatoid arthritis is basically to relieve pain, decrease inflammation, as well as promote quality of life for patients. We want these individuals to be able to participate in activities of daily living or ADLs as much as they can and as much as possible. For diet, we want patients to increase protein and calcium intake to prevent anemia. They may need to also take something like an iron supplement. We also encourage eating small, frequent meals throughout the day. For exercise, range of motion and joint strengthening is needed for mobility of that joint. More importantly, weight-bearing exercises ensures that the muscles around that joint are strong enough to support that joint. Now, this can be a big challenge for your rheumatoid arthritis patients because they are in a lot of discomfort. Medical treatment could be aggressive for those who have more aggressive forms of rheumatoid arthritis. A lot is going to depend on what their labs look like and what kind of symptoms they have. Control of modifiable factors include smoking cessation, inactivity, and poor nutrition. Analgesics, again, will help with pain, which will ultimately help with mobility and quality of life. For rheumatoid arthritis management, patients require a multimodal pain management, meaning they're going to need multiple methods for pain relief. Non-pharmacological methods include things like chemotherapy, rest, and positioning. Some may also benefit from splints. Again, exercise is really important for these patients. Some may really benefit from things like physical therapy and occupational therapy. Complementary therapies include something like cupping or acupuncture or massage. Self-help or support groups can also be really beneficial for these individuals, to have a support group in general, but also to help them to develop positive coping mechanisms. Surgery may also be needed down the line, such as a synovectomy. There is no cure for rheumatoid arthritis. This is a lifelong condition that will require multiple factors in order to relieve pain that they may endure, but also to slow the progression. Again, education is important. Education about diet and how they can conserve energy so that they can still participate in their activities that they enjoy. Also, don't forget education on medications that they may be prescribed, as well as the potential side effects of them. Self-care and stress management too is very important for these patients. If they are not caring for themselves when they have increased stress, they're going to have more frequent exacerbations or flare-ups of rheumatoid arthritis. Here is a depiction of a synovectomy. This is a surgery that can be done to remove synovium from the joints of patients who have chronic inflammation due to rheumatoid arthritis. A common area for this surgery is the knee. Now let's review osteoarthritis or degenerative joint disease. This disorder is when there is depletion of some of the cartilage of the joint. The joints most commonly affected are those who have a lot of weight bearing, such as the hips and the knees. Remember, with a normal joint, you have hyaline cartilage that will provide cushion to the bones. With osteoarthritis, cartilage is decreased or depleted. Thus, there is higher risk of bones rubbing against each other, causing pain and discomfort for these patients. Osteoarthritis is a non-inflammatory, localized disorder that can cause unilateral joint pain and stiffness. Osteoarthritis is characterized by the progressive deterioration and loss of our articular cartilage and bone in one or more joints. Osteoarthritis is caused by a combination of aging and genetic factors, with weight-bearing joints most commonly being affected. This degenerative joint disease affects the cartilage and surrounding tissues. It is the most common type of arthritis and is characterized by breakdown of cartilage leading to joint pain, stiffness, and limited mobility. Some risk factors for osteoarthritis includes age. Osteoarthritis is more common in older adults. Obesity. Excess weight puts additional stress on their joints, increasing their risk for osteoarthritis. Joint injury. Current, repeated, or history of trauma and stress to a joint can increase the risk of osteoarthritis. Chronic joint disease. Basically, conditions such as rheumatoid arthritis can also increase the risk of osteoarthritis. And metabolic disorders such as diabetes can also increase the risk of osteoarthritis. Some common signs and symptoms of osteoarthritis include joint pain, pain to the joints, especially after movement or during high activity levels, stiffness that is often worse in the morning or after sitting for extended periods, swelling, basically inflammation around the affected joints, which leads to swelling, and then reduced range of motion, basically decreased flexibility and the ability to move the joint normally. And there's also crepitus, a grating sensation or sound that may occur when moving the affected joints. Diagnosis of osteoarthritis is based on history, course, and physical examination. Radiologic changes and possibly supported by lab results as well. X-rays are best to determine the structural joint changes and show severity of the disease. Still, clinical findings and radiologic exams do not determine pain level for patients. Keep that in mind. Also, there are no definitive lab tests for osteoarthritis. Results are usually normal, but they may be helpful in screening for other associated conditions. Okay, so drug therapy for osteoarthritis. There are non-opioid analgesics that we can use, such as acetaminophen. This is the recommended primary drug of choice for osteoarthritis to treat pain. Usually one is not to exceed 4,000 milligrams per day. Patients can take 1 to 2 tabs every 4 to 6 hours as needed. When using acetaminophen or Tylenol, we have to be careful. There is risk for hepatotoxicity, so patients should be cautious and they shouldn't be drinking alcohol when taking acetaminophen. We also have tramadol. It has weak opioid properties and it can be used in combination with acetaminophen. We also can use aspirin. Again, it may be associated with GI bleed if used in high doses, so we got to be careful with that and educate our patients. We also have steroids that patients can use, and they may be prescribed for shorter term use to relieve pain and inflammation. Examples of NSAIDs include ibuprofen or Advil, ketoprofen, naproxen. These are all available over the counter. Some prescription NSAIDs include diclofenac or Voltaren gel, and many others. For these, you need a prescription from a provider. Again, all these NSAIDs, there is a greater risk for GI bleeds and renal failure if used in high doses. So we have to educate patients and be careful with that. And it's always recommended if they are taking NSAIDs to be taken with food. For our COX-2 inhibitors, they are in the NSAID category, but they do not cause as much GI irritation. Examples include Celebrex, which I believe is also prescribed by a doctor. The goal of treatment is basically to decrease tenderness with pressure, decrease pain at rest and with motion, nighttime pain, stiffness and swelling, and improve range of motion for these patients. Opioid analgesics include oxycodone or codeine. They are effective at pain control, but short-term use is recommended due to the dependency concerns. Intraocular injections can be beneficial for patients who can't use NSAIDs or other analgesics. With these injections, basically hyaluronic acid is a natural substance that acts as a lubricant and shock absorber in joints. So with osteoarthritis, there is lower levels of this acid in the joints. The injections are intended to replace the lost acid and thus reduces the symptoms of these patients. Side effects of these injections include feeling mild pain, swelling, redness. They can develop a rash, some itching or bruising around the site. People with skin disease should not have these injections. Osteoarthritis treatments focuses on managing symptoms and slowing disease progression. Treatment options include non-pharmacological therapy, such as patient education, dietary information, as well as physical and occupational therapy. A multidisciplinary approach to treat osteoarthritis is very common. Non-pharmacological interventions are essential in managing osteoarthritis. Basically, they can help reduce pain, improve joint function, and enhance overall quality of life. We can decrease incidence of osteoarthritis by teaching about importance of good health nutrition to prevent obesity and complications. Engaging in low-impact exercises such as walking, swimming, or cycling is important to maintain joint mobility and strength. Ergonomics can also play a role in prevention, such as proper posture, maintaining good posture to reduce strain on the vertebral column. With obesity on the rise, it is a big concern with osteoarthritis because it can decrease physical activity and increase pain in these patients. This being so, weight loss is highly encouraged for overweight individuals to reduce pressure on weight-bearing joints. Moist heat and ice can be used to relieve pain and stiffness. Heat therapy includes relaxing the muscles by reducing pain and stiffness. We want to avoid burns when using heat therapy, so use temperatures just above body temperature, but make sure it's not too hot. There's also cold therapy, which numbs nerve endings and helps reduce inflammation. But we want to limit the use because it's not too effective for most patients. There's also massage, which helps with pain and stiffness in affected joints. And then there's also assistive devices that we can use. Basically, they may be needed for mobility and help with daily activities such as canes, and we'll be discussing more equipment later on in the lecture. Surgical procedures for osteoarthritis include laparoscopic surgery to remove bone spurs or joint replacements. They may be performed on patients with severe cases of osteoarthritis when other non-surgical interventions have failed. They include arthroscopic surgery, such as total joint irrigation, debridement, osteotomy, or total joint replacement. Joint replacements can be used for both osteoarthritis and rheumatoid arthritis. Here is a table for you guys to review. It lists differences between osteoarthritis and rheumatoid arthritis. Treatment goals and outcomes will be similar for osteoarthritis and rheumatoid arthritis. But with rheumatoid arthritis, because it is an autoimmune dysfunction, they have high risk for deformities if they don't receive treatment for it. Now, we will be reviewing gout as well. This is another form of arthritis. It is considered to be a systemic metabolic disease in which uric crystals deposit into the joints and cause a lot of inflammation and severe pain. So gout is the only curable arthritis, and this is because of an increased amount of uric acid in the body. Thus, limiting it in the body can reverse its symptoms. Gout is a systematic metabolic disease characterized by increased uric acid levels in the body. These urate crystals deposit into the joints, causing, again, inflammation and severe pain for patients. There are types of gout. Primary gout is the more common type, and there is a genetic disposition to it. Basically, there is an issue with purine metabolism. And then with secondary gout, there is elevated uric acid levels due to other diseases or medications that are causing the elevated levels. Examples include patients who suffer from renal insufficiency or those who take diuretics. Signs and symptoms of gout includes pain and inflammation, as mentioned earlier, in the affected joint. There's also acute attacks, which often occurs in the great toe. Chronic gout is when there are repeated attacks with remission and exacerbation episodes. Diagnosis of gout includes attaining history and doing a physical examination on patients, blood draw to determine serum uric acid levels. There's renal function lab evaluation and arthrocentesis. That is when joint is aspirated and tested for presence of uric acid crystals. Management of gout includes medications such as colchicine and NSAIDs to reduce inflammation. Allopurinol is a common medication that we'll see, and it helps by increasing uric acid excretion by the body. Medications to avoid include aspirin, diuretics, and alcohol, because this does increase uric acid levels in the body. And there's also dietary changes or recommendations that patients should follow, including following a low purine diet and increasing fluid intake. Next, we will also cover osteoporosis and a metabolic bone disease. Osteoporosis is a chronic disease of cellular regulation in which bone loss causes significant decreased density and possible fractures. This demineralization of bones is more prone after menopause. Essentially, what happens is that bone minerals are reabsorbed into circulation due to need. The breakdown and reabsorption is faster than bone formation, leading to weakened bone matrix. The inside of the bone becomes porous, brittle, and weak, thus fractures can easily occur. Osteoporosis can be caused by a combination of genetic, lifestyle, and environmental factors. Osteoporosis is a condition that affects the bones, making them weak and brittle. It is often referred to as a silent disease because it can progress without any noticeable symptoms until a fracture occurs. There is high incidence of osteoporosis in Euro-Caucasian or Asian ethnicities, those who have gone through menopause, or there's a history of total hysterectomy, including the removal of ovaries, so more common in women. Those that are older in age, those over 50 years of age, and as well as their family history. If there's family history of osteoporosis, that's also high incidence for it. Eating disorders such as anorexia nervosa, rheumatoid arthritis, and history of low trauma fractures after the age of 50, such as hip fractures. Etiology of some possibly modifiable risk factors includes estrogen or androgen deficiency seen in postmenopausal women, inactivity or lack of physical exercise or prolonged decreased mobility, low body weight, thin build or lean body mass, poor nutrition or dietary deficiencies, such as chronic low calcium and or vitamin D intake, smoking, active or passive smoking, and high alcohol and caffeine intake, as well as drug therapy, such as chronic steroid therapy. Signs and symptoms of osteoporosis includes bone fractures. Basically, there's increased susceptibility to fractures, especially in the wrist, hip, and spine. There's loss of height, a noticeable decrease in height over time due to vertebral compression. There's postural changes, development of a stoop posture or hunchback appearance, such as kyphosis and outward curvature of the thoracic spine, causing a humped back. There's also pain, chronic pain in the back caused by fractures or collapsed vertebrae, as well as joints, and weakness, general weakness or a feeling of fragility. Some nursing care includes range of motion and weight-bearing exercises, promotion of safety, and ADLs. Osteoporosis is a disease that affects bone density, making bones more susceptible to fractures. Nutrition plays a crucial role in the development and management of osteoporosis. There's recommended nutrients for bone health, which includes calcium intake, vitamin D intake, and protein intake. Exercise, again, is essential for maintaining strong bones and preventing osteoporosis. Weight-bearing exercise is particularly effective in promoting bone health. So weight-bearing exercises such as walking can help build bone tissue. Again, adequate calcium and vitamin D intake is essential for bone health. The recommended dose for calcium intake is about 1,500 milligrams per day for postmenopausal women and men between the ages of 50 to 70 years old. Vitamin D supplementation is also recommended, usually about 1,000 units per day. Drug therapy is used to slow bone reabsorption and form new bone tissues. So biphosphonates are the most common drugs used for osteoporosis treatment. There's also alendronic acid or Fosamax, which are common biphosphonate medications prescribed for osteoporosis prevention and treatment. Fractures are breaks in the bone, often caused by osteoporosis, trauma, or falls. Common types of fractures include hip fractures, wrist fractures, example, Colles fracture. There's also spinal fractures or vertebral compression fractures. Causes of fractures are usually osteoporosis, trauma, or falls, as mentioned earlier. Hip fracture is a common injury in older adults with a high mortality rate due to multiple complications related to surgery, such as decreased mobility, development of pneumonia, and even depression. Here we can see the different types of hip fractures that can occur. It includes intracapsular and extracapsular fractures. This just gives you an idea of how these fractures may affect individuals in different ways and what kind of surgeries they may need. Here we have a depiction of a balloon kyphoplasty procedure. This procedure is done to treat compression fractures of the spinal column. Basically, what is done is that a little balloon is inflated inside of the vertebra. After being inflated, the bone cement is injected in there in order to keep it inflated. By filling in the balloon space, the vertebra return to a somewhat original or normal shape or width and height. This helps by stabilizing the vertebra compression fracture and thus relieving pain for patients. Again, a very common type of wrist fracture is the Colles wrist fracture. This fracture occurs when someone is trying to break a fall. We naturally do this by extending out our hands in front of us as we fall down. These falls basically cause a break on the wrist, and treatment is usually a fixed or closed reduction, basically a manual reduction. And this is basically when realignment of the bone is done without making a surgical incision. Essentially, we are manipulating the bone fragments back into place externally. And this is done by the doctors, not us. So when doing this reduction, it typically does require an anesthetic nerve block so that patients don't feel pain. Lidocaine may be administered before so that they can numb up the nerve and the individual doesn't feel their hand. Once the reduction is done, a cast can then be applied. Now, imagine if a patient with this fracture also had a hip fracture. It's going to be very difficult for them, right? Why do you think? They may not be able to use a front wheel walker properly or at all. Some walkers have an armrest attachment to it, but some people may not like using it or may easily get frustrated trying to use it properly. So these patients also cannot use crutches due to arm restrictions. This being the case, there's just many safety concerns for these patients with these fractures. Signs and symptoms of fractures are usually deformity of the affected area. There may be changes in circulation, sensation, and motion. This is the CSM, as well as swelling, ecchymosis, bruising, and pain. Some may have numbness and tingling of the distal portion of that extremity. There may have also loss of function, which would include a lot of pain with movement. Diagnosis of fractures includes gathering history and physical data, but more importantly, x-rays. This helps to confirm whether or not there is a fracture present. So, pre-op diagnosis as well as labs includes CBC with electrolytes. This is usually needed by anesthesiology mostly. An EKG, a chest x-ray, and a urinalysis could also be done if they are going to have something like a hip fracture repair, because they will have to be under complete anesthesia. There's also clotting factors such as PT, PTT, and INR, which will also be done if they are going to have open surgery. Basically, doctors just want to make sure patients won't bleed out during surgery, right? So, post-hip fracture repair, it's very important to keep the affected extremity and joints immobilized. This being so, a splint and natural position for comfort is important. Equipment that you may see to help keep limbs in place is post-ankle surgery is a buck traction. It's not always used. Not too common, but it is available for patients, and it can help keep the bone aligned for these patients. When not using such equipment, we use blankets and pillows to elevate limbs and relieve pressure on heels. With compound fractures or open fractures, basically bone is sticking out through the skin. If this happens, it's important to do basic wound care. So we keep the wound covered with a dry, sterile dressing to prevent any bacteria from getting in there until they're able to have surgery. Neurovascular assessments are very important because we worry about poor circulation to the distal portion of the extremity. We don't want to lose limbs, right? So again, we must assess CSM, which is circulation, sensation, and motion or movement. We also need to assess the 6 P's, which are paresthesia, pain, pressure, pallor, paralysis, and pulselessness. Now, with a reduction or repair, there are 2 types of fracture treatments. There's closed or manual reduction, which is usually done for minor fractures that can be reduced or bones basically being put back in place without opening the patient up for surgery. And an x-ray can be done afterwards to make sure that bones are back in place. And then there's also open repair, or an ORIF, which is the acronym for open reduction internal fixation. These are surgical repairs of compound fractures, basically when there's multiple fractures due to bones being shattered. So there are several complications that can occur due to fracture surgical repairs. A big one is immobility. This can lead to infection in the lungs, causing pneumonia, and this being so, it's very important to encourage intensive spirometry use post-surgery. There's also complication of fat embolisms, which can occur with more severe fractures. And then there's also the worry for DVTs or pulmonary embolisms being developed. This is usually due to immobility, right? I don't know if you guys remember, but basically what happens is that there's stasis of blood in the lower extremities due to immobility, and this stasis basically causes, it can cause blood clots to form, and with circulation, they can get caught in the legs easily, or they can even move up in circulation and towards the lung area. So that's the big one. And then there's also the complication of renal calculi being developed, also pressure ulcers due to immobility, and there's also joint contractures or disability which can occur due to immobility. So because of these complications, we have to try to move our patients every 2 hours. But remember to be mindful of any restrictions of the joint or the bone. Post-op hip dislocation is also a big concern post hip surgeries. If the dislocation does occur, the patient will experience severe pain. So you'll definitely probably start assessing for that right away if a patient complains of severe pain. You might notice a shortened limb, and they will not be able to move much, or even rotate the hip. And if this happens, it is very important that you do not attempt to put the hip back in place. You can cause more damage if you do that, and it's not in our scope of practice. So only doctors can do it. They're the only ones that can put it back in place. So this being so, you definitely want to call the surgeon so that they can come and do a manual reduction, and maybe even order medications to keep patients comfortable, because it's going to be painful. Okay, so pre-op care. There's JCO core measures that will be discussed in pre-op care, more covered in N196. So for this course, we're basically just going to cover pre-op care that's listed as follows. And it includes attaining a baseline of things that we can monitor during and after surgery, right? So this includes our ABCs, making sure our patients are oxygenating well, and we know what, if they are on room air, if they required oxygen before surgery, something that we're going to monitor even afterwards. What is their level of consciousness at baseline before surgery, right? So remember, elderly patients can be disoriented due to trauma, shock, and even medications. So we need to make sure that we monitor patients so that we can determine if something new is happening with patients, including their mentation status, pre and post surgery. And then we also want to make sure that we monitor patients' intakes and outputs. Fluids, we are giving fluids, so we want to make sure that we are monitoring what's coming out. We want to make sure that we are monitoring and determining if patients are maybe developing some renal impairment, or even if they had it beforehand. We also want to assess the fracture area. So assess CSM often, at least every 2 hours, to monitor the progression of it and just to make sure nothing, is going on. And what is their pain level before giving the meds? What medications work for them? When was their last meal? What type of diet do they normally have at home? Before surgery, MPO diet may be in effect, meaning they might be fasting. After surgery, patients may be started on clear liquids and advance slowly as patients can tolerate. We make sure patients are awake and alert before we try to feed them. So don't forget your nursing bedside swallow after surgery. And then we also have dressing changes, which usually are done based on doctor orders, so always clarify. For orthopedic surgeries, the initial dressing changes should always be done by the surgeon, so keep that in mind. Patients will be started on DVT prophylaxis if possible as well. This includes short-term anticoagulants such as heparin or Lovenox injections. And the biggest thing is safety. It's important for these patients because they have many mobility limitations probably, right? After anesthesia, and then on top of that, their fracture, their surgery. So there's mobility limitations pre and post surgery. Okay, so here we have examples of total joint replacements or arthroplasty. The shoulder and hip look a little similar due to both having a ball and socket joint. If you notice, the knee is a hinge joint. So here we have the hip and knee joint replacements depicted again. With post-op care, again, postural restrictions for hip replacements are going to depend on what kind of approach the surgery team had or the surgeon had. So with posterior approach in the surgery, patients must follow traditional hip precautions. They should not be adducting or flexing more than 60 to 90 degrees or internally rotating their foot. With anterior approaches to surgery, there's precautions that includes no extreme abduction, no hyperextension, and no extreme external rotation, as well as no pointing the toes in outward. All these patients need to avoid prolonged knee flexion, and they should not be doing any weight-bearing restrictions unless they have been evaluated by physical therapy. So physical therapy will determine how much weight-bearing they can have, as well as the surgeon. Here is an image showing a do not list for hip replacement surgery patients. Us as nurses and also the physical therapists, occupational therapists, and even the doctors, we're all responsible for educating our patients on all of these restrictions. And usually the hospitals do have a lot of good education for patients. And if anything, you can always ask your physical therapist and occupational therapist. This is their specialty, so they're really good at educating our patients on these restrictions as well. So we also want to use pillows post-op or after hip replacement, and that is using the abduction pillow, which can be provided to patients to prevent any injury after surgery. So basically these pillows don't allow patients to bring their legs together, and here we have a picture showing you guys what they look like. If you don't have an abduction pillow, you can use a regular pillow or just put it between the legs, but be careful, of course. Avoid putting pressure over surgical sites. So, nursing implications. It's important to teach your patients what to expect after surgery. This helps them to mentally prepare with what they should expect, and it also helps the family members to prepare for after surgery, right? So think if this was you. A fracture is unexpected, right? And it's normal for patients to feel anxious about going into surgery, something that, can be big for people. So again, it's important to educate your patients on what to expect before and after surgery. This can also help reduce some anxiety that they may be experiencing before surgery. So it also helps to identify what patients' goals are after surgery. We have to help patients identify realistic goals, right? So some individuals will not be able to go home. They might need to go to a nursing home or a rehab center, or they might be able to go home, but, with aid of home health assistance such as physical therapy or, nursing care, caregiving care. It just depends on what their needs are. Common equipment upon discharge may include front wheel walker, which I'm sure you guys have seen in the hospitals, and they may also need an elevated toilet or even a trigger reacher for smaller items that that are out of reach. There's also a sock applicator, which can be useful for patients. And with this, basically, you just put the sock on the equipment and it enables you to easily slide your foot in. So you don't have to bend at a 90-degree angle or more in order to prevent popping, that hip out or anything. So again, high-seated chairs or toilet seats do prevent flexion. So they're common equipment that can be ordered for patients upon discharge and be used in the hospitals as well. So again, here is a raised toilet seat and a commode picture again. The biggest risk is going to be upon rising for these patients when using these. So if they are in a sitting position, having something like an armchair is going to be very helpful, as well as a front wheel walker and maybe some assistance in order to stand. Physical therapy is going to be really important for mobility so that they can start to exercise those muscles and improve their outcomes, and also learn what their limitations are so that they can learn to move safely, right? Occupational therapy is also really helpful with ADL training, and we have some images here that you guys can check out. Here are more adaptive devices. We have again the trigger reacher, which is helpful to grab hard to reach items. And here is also an image of a shoehorn. This basically helps patients put on shoes without bending much. Okay, so for nursing implications, again, due to immobility complications, we can help patients with range of motion exercises while they are in bed. We do have to leave the affected extremity alone until physical therapy, evaluates them and tells us their restrictions if there are any. Other complications that can occur include atelectasis. This is a reversible collapse of a part of the lung, and basically using intensive spirometry is important to help fully expand these lungs and exercise them. So encouraging patients to use it is important after surgery. There's also the complication of constipation due to immobility and side effects of basically narcotic medication use, right? So if this does occur, we want to make sure patients are being well hydrated, that they move if possible, and maybe even use stool softeners may be indicated. There may also be complications of anemia. Basically, if there was a lot of bleeding during surgery, again, we worry about dislocations, right? So if they had a hip replacement, what movements should they not be using and which ones can they use? And then there's also sexual activity teaching, which is another important factor. Your older adults are still sexually active, or they can be sexually active, so it's really important to educate them on that if they are comfortable with it. So for post-op nursing implications, again, we want to monitor intakes and outputs, and that is basically us monitoring what is going in and out of our patients. Especially if they have Foleys, this makes it a lot easier for us to monitor output. And again, after surgery, most patients will start their diets with clear liquids, and first we see how they tolerate it, and then they can slowly progress onto a regular diet. And there's also individuals who have issues with, again, constipation due to pain medications and immobility. So we want to increase water intake, but also maybe encourage an increased fiber intake, and stool softeners may be needed. Here are other assistive devices. We have a shower chair, which enables patients to sit while they wash up. And then we also have a 3-in-1 commode, and this can be elevated if needed. It can be used as a shower chair, a commode, and it can also be put as an elevated seat that can be placed over the toilet as well. Here are STDs, again, or sequential compression devices. Basically, they help with circulation. In addition to STDs, patients can also be prescribed TED hose, which are tight compression stockings that help with circulation as well. They both help with preventing DVTs. This image here provides more education on how to properly use a cane. It's important to tell your patients to use a cane on the unaffected side. They should not be using it on the affected side. This is not correct. Okay, so splints after surgery is common for both total knee and hip replacements. There's also waterproof dressings that can be applied over surgical incisions. And there's also bulky splints that can be temporary or until the surgeon has cleared them from being used. There's also drains that can be placed depending on the surgery that the patient had. The more common one is the JP drain. For pain management, it's going to be essential for patients after surgery. Usually, knees are more painful than the hips, and these patients just need medications before working with physical therapy. And we want to do this because we do want them to participate fully with physical therapy or even occupational therapy. For both knee and hip replacement patients, our goal is to get them up and out of bed within 24 hours. With a shoulder arthroplasty, there's typically a shoulder splint like this one in the image here, and they can keep it in a correct alignment. It's really important that they wear this, so you really have to reinforce and educate because it is not really the most comfortable thing for them to wear, but it does help with healing properly. And also don't forget CSM. It is important that we regularly check and see if their fingers are able to move, if they can feel everything, or if their skin is in a consistently normal color, right? We continuously monitor for any abnormalities, even after surgery. Okay, so now let's talk about falls. And so falls are the second leading cause of accidental deaths, and these are very preventable. So patients need to pay attention to where they're walking and know their limitations, right? 75% of the falls do involve elderly, and unfortunately, it's usually caused by simple things like getting up too fast or simply because they may not be using their assistive devices, right? So many of these falls do happen at night. They may happen at home, and they also happen during change of shift. So at nighttime, it's usually because there's poor lighting, and maybe they're getting up in the middle of the night to use the bathroom. Maybe it's just sleepy, right? There are risk factors for falls, and that includes sensory perception. So patients may have issues with hearing or seeing, so they do have increased risk for falls. There's also altered mental status, which is a major one, especially with elderly. So in acute care settings, they sometimes have delirium, which makes them even more confused and maybe even impulsive, making them a big fall risk, right? And then we also have general weakness, which is another one. So some older adults are really determined to maintain their independence, so they may get up on their own without asking for help. And then there's basically our primary concern and with nursing is to prevent these falls from occurring. So we always want to make sure we are assessing their environment, right? Make sure that there's nothing that can cause the patient to fall or trip. So you want to make sure that nightlight is on and there's enough lighting, it's appropriate, and that there are no rugs in the home if you are assessing the home, and that they do have non-skid flooring if possible. So in the hospital, that's why we try to make sure that non-skid socks are on these patients at all times. Okay, so additional assessment data that we obtain for individuals is what was their previous level of functioning, right? So this helps us identify their goal and what they would most likely want to get back to. So, for example, with hip fracture patients who are undergoing surgery, how are we gonna get them to their previous level of functioning? So that they don't have any long-term effects, right? Imagine they had 4 ADLs prior to the hip fracture and hip replacement surgery. Now, they probably won't go back to anything higher than their previous level of functioning, which is 4. So if we can get as close as possible to that, then that's a good goal in itself. Still, with our older adults, we do want them to maintain their independence, and we do help them as much as we can, but by them maintaining their independence, it does help them a lot with their self-confidence, and it helps them to maintain independence, and it also helps increase their mobility. So if they're able to dress themselves, brush their teeth by themselves, things like that, you should encourage them to do it themselves. Don't try to do it for them. You want to make sure that they maintain as much independence as possible, right? Remember, if they don't use it, they lose it. So we want to make sure that they don't become dependent on us and that they are exercising these muscles and doing these activities independently. Okay, so this concludes this lecture on musculoskeletal system and the older adult. If you have any questions, please feel free to email me and I will respond as soon as I am able to.